our session of just cases, diagnostic and surgical challenges in glaucoma. Can I just know who all are the speakers present? Prerna Garg, I can see. Bimlesh Ojha, yeah. Ankur Singh, yeah. Niharika Batra, Barkha Chaudhary, Mehak Gupta, Vidushi Dikshit. Okay. So we start with the first speaker, Prerna Garg, and she is going to present on looking beyond the intraocular pressure in cases of juvenile glaucoma. Please stick to your time, which is of 4 minutes each. Okay.
Good morning, everyone. So I will be presenting 2 cases of juvenile glaucoma in which there were other findings other than the increased intraocular pressure and the glaucoma. The first case was of a 37-year-old male who presented with very high IOPs and a vision of finger counting half meter in both the eyes. And he gave history of getting trabeculectomy done 4 to 5 years back, followed by bleb needling. He was lost to follow-up since the last 4 years, and there was no other positive family history. Both eyes had similar findings. In both eyes, the pupil was mid-dilated with ectropion uvea with neovascular NVI present. The angles were open with intermittent goniosynic. There was a bleb in the supranosal quadrant in both the eyes, which was encysted and congested. And these are the fundus photos. Now, the photos were taken once some amount of treatment has already been started. In the right head, we can see that the disc was of near total cupping, and the vessels had perivascular sheathing. Few laser spots can be seen as laser had already been started for the NVI. In left eye, he had similar findings. There was severe perivascular sheathing with multiple scattered subretinal hemorrhages. There was also inferior vitreous hemorrhage, which was present at that time of when he showed to us first. His systemic investigations were ordered, thinking that it might be vasculitis induced, looking at his age, 37 years, or it might be CRVO, late resolving CRVO, or a late onset CRVO. And the investigations, however, all came out to be normal, other than a slight increase in the cholesterol. His homocysteine levels were high, and remaining else, everything was normal. So a diagnosis of NVG secondary to still a vasculitis diagnosis was kept, or a bilateral CRVO was kept. And in previous papers, there was no mention of any retinal disease, which was done when trabeculectomy was done 4 years back. He was diagnosed as a case of juvenile open-angle glaucoma. So his treatment was started, prednisolone, acetate, atropine, all the anti-glaucoma medications possible except the PG analogs and pilocarpine. Anti-VEGF injections were given, retinal laser was done, and IOP was not decreasing. So the IOP was very high at that time, more than 40. So the only treatment which could be done was an inferior 180-degree DLCP was done. And IOP decreased to 20 on MMT for 1 month, but increased again. It kept on increasing, so he was planned for trabeculectomy in the right eye. The IOP decreased again for a few weeks. However, following a minor injury, it again increased. The vision in the right eye remained same, finger counting 0.5 meter, whereas it improved to 6/60 to 636 in the left eye, which was attributed to right eye macular ischemia. In this, we can see the GCL layer was thinned out. And the left eye kept on increasing. He also developed cataract eventually. So we were wondering what to do next. The options were a re-trabeculectomy in the left eye, a tube implant, or a re-TSCPC, or some nowadays goniosynovial lysis with MIGS, and also whether the trab or tube should be done along with the cataract surgery or without it. So he underwent a tube implant eventually just 1 or 2 weeks back, and that has been doing well since the last 2 weeks. What makes this case unique is that there were unexpected peripheral retinal findings which might have been missed 4 years back when he was diagnosed as GOAG. And this led to the NVI and NVG happening in both the cases. The only thing which was present was increased homocysteine levels. So after this case, I just thought that, when we diagnose GOAG, when we see advanced glaucoma in a young male and open angles, we always diagnose them as GOAG. We never get the retina examination done, which should be done in these patients. The second case was a 30-year-old male who presented, he was actually diagnosed with GOAG only, high IOPs in both eyes. His fundus was grossly normal. There was no vasculitis. The only finding which we could see when we did an OCT macula was the presence of this retinoschisis, which was either a juvenile retinoschisis or a retinoschisis induced by high IOP. We don't know, but there was some associated finding along with the advanced glaucoma. He was just 30 years of age with very advanced glaucoma. So the point to remember, which I feel, was that in all young patients presenting with high IOP, retina examination should not be missed, including a peripheral retinal examination. That should also be done. Thank you.
Yeah, very nice cases, Prerna. In the first case, you found in the systemic investigations only serum homocysteine was raised.
Yes, so,
And angles also showed neovascularization.
so at the time of when he came first, there was no neovascularization of the angle. There was just intermittent goniosynic. There was severe, like grade 3 to 3 NVI was present, but NVA was not present. But eventually he did develop, closed
NVA.
angle, NVA and closed angle. Because the NVI kept on coming back and again. He's already received around 7 to 8 in the last 1 year, 7 to 8 injections of anti-VEGF because the NVI kept on coming every 1.5 months. And the bleb kept on becoming encysted and very congested. In spite of the total retinal laser, PRP, everything was done in spite of that. So finally, to save his left eye, all the vessels were sclerosed, but he still had 660 vision. So a tube implant was done in the supratemporal quadrant. And that's just been 2 weeks right now. So that is functioning. There's a cataract, so that was not touched. But it's functioning well for now. The pressure is around 8 to 9 millimeter mercury on no AGM. So for now.
So it's well controlled.
For now, sir.
But you didn't think about doing combined surgery because
no,
of
pressure
cataract
was
also?
in 40s on Dimox, all the
So this was most probably post-venous occlusion, neovascular glaucoma in
yes,
this patient.
Yes, sir.
Yeah. Okay. Thank you. So now we have Dr. Bimlesh Ojha. And Dr. Bimlesh Ojha is going to present his case on pigment dispersion syndrome and pigmentary glaucoma secondary to ocular trauma in a young male.
Good morning, everyone. Myself, Dr. Bimlesh Ojha, Assistant Professor in GMC, Satna, MP. A 26-year-old male presented with chief complaint of pain in left eye since 15 days, which was insidious in onset, mild in intensity, dull in nature, and persistent throughout the day. Patient also complained of blurring of vision and redness in his left eye following blunt trauma since 15 days. There was no family history of headache, hypertension, and diabetes. And on ocular examination, anterior segment examination in right eye, visual acuity was normal and all findings were normal. In left eye, visual acuity 560 and improving up to 626 with pinhole, and intraocular pressure was 20 mmHg by Goldman illumination tonometer, and central corneal thickness was 502. On diffuse light examination, there was ciliary and conjunctival congestion, and in slit lamp microvulli in the central part of the cornea, and iris pigment dispersion on the back of the cornea, and anterior lens capsule also. On gonioscopic finding, having an uniformly homogeneously pigmented trabecular meshwork and widely open up to the grade 4. On fundus examination, media was clear and optic disc normal. Only cup disc ratio 0.7 and temporal rim thinning was found. In OCT RNFL also, vertical cup disc ratio 0.71 and superior temporal rim thinning was found. On the basis of ocular finding, my differential diagnosis is pigment dispersion syndrome with pigmentary glaucoma, pseudoexfoliative glaucoma, and uveitic glaucoma. In pseudoexfoliative glaucoma, mostly present in older age, and the pigmented deposition is unevenly, not homogeneous, so rule out the pseudoexfoliative glaucoma. And uveitic glaucoma, there was a cells in uveitic glaucoma, cells found in anterior segment, but in my case, there was no cells in anterior segment or not in anterior vitreous also. On anterior segment OCT, the posterior concavity of the mid peripheral iris, and pachymetry, the central corneal thickness is 502 micron. On SVF, the central 24-2 threshold test, the test was reliable because fixation loss is less than 20% and false positive and false negative is less than 33%, and they follow the Anderson criteria because GST is outside normal limit and pigment pattern standard deviation is less than 1%. So my probable diagnosis is left eye pigment dispersion syndrome with pigmentary glaucoma, and that time the treatment started with the estazolamide 250 mg twice a day with the port chlor syrup, and locally in left eye eye drop travoprost, brinzolamide and timolol was added. So post-treatment, day 4, visual acuity improved up to 618 and intraocular pressure reduced up to 22 mmHg. Treatment advice on discharge, travoprost, brinzolamide and timolol, and advice 3-monthly follow-up to see the progression of the optic atrophy and glaucoma progression. So take home message, this case is being presented to warn the doctors to thoroughly check any young ametropic male patients who presented with the above mentioned complaints following ocular trauma, as it may be related to pigment dispersion syndrome. Patients who have increased intraocular pressure and iris pigment dispersion should be handled carefully and as soon as possible. These patients need to be advised about the long-term effects of illness and give advice regarding the hereditary nature of the syndromes. Thank you.
Yeah, very nice presentation, Bimlesh.
Thank you, sir.
What were the findings on gonioscopy?
Sir, gonioscopy, sir, dense homogeneously pigmentation in the trabecular meshmark and sir, widely open angle, grade 4.
Okay. No widening of the ciliary band?
No, sir, there is no longitudinal ciliary muscles or no separations.
Evidence of trauma
No.
apart from this? Okay,
Yes.
okay. I think very good case, Bimlesh. Thank you.
Thank you so much. Good day.
Now we have Dr. Ankur Singh. Dr. Ankur Singh is going to present on lens-induced glaucoma or endophthalmitis, a diagnostic dilemma unfolded.
So the dilemma is already open now. Very good morning. I'm going to talk about a patient, and I want my audience to be a bit interactive. This is a 78-year-old male who presented with decrease of vision for 2 years in the left eye, with progressive painful worsening of the vision in last 2 weeks. No history of trauma or any other ocular surgery, with a history of pulmonary TB on ATT currently for last 6 months. Look at this image. He had an hand movement close to face with an IOP of 40, diffuse circumcorneal congestion, boggy iris, hypopyon or pseudohypopyon, and a yellow glow. So what do you think is the diagnosis? End of? Probably. So what you would do? You would do an ultrasound B scan. So I did the same thing. So I did an ultrasound B scan in this patient, and I found multiple pinpoint echos with mild echogenicity. Then I looked at the retinochoroid thickness. It was okay. So because it was okay, I made a diagnosis. I made a two differential diagnosis. The primary diagnosis was lens-induced glaucoma, a lens particle glaucoma type. Still, I kept the endogenous endophthalmitis as a differential diagnosis as well. So to rule out the diagnosis, I did a UBM. Look at the UBM at this patient. Do you see the partially absorbed lens in this patient now? The one that is shown with the star? So now the diagnosis was confirmed. It was a lens-induced glaucoma, which looked like endophthalmitis initially, but the IOP was high, but it is a phacolytic glaucoma. So I managed the IOP with the IV mannitol, syrup glycerol, oral acetazolamide, topical timolol maleate. Inflammation was controlled by prednisolone acetate drops, topical cycloplegics, as well as a 30 mg 30 mg tablet prednisolone. So being a retina surgeon by myself, I planned a 23 gauge pars plana vitrectomy with lensectomy, and I still thought, let's just keep the endophthalmitis still there, because me being a retina surgeon, I look for endophthalmitis, not glaucoma. So I did an intraoperative, this is the intraoperative images. I just want to draw your attention to the lower third image. Look at how small the nucleus has become. This is how it was lying in the vitreous cavity with those few fluffy exudate. And this was a nucleus that was absorbed. It was, and it because the posterior capsule gave way, it came into the vitreous cavity. So what I did is then I left the patient aphakic because I was suspecting certain edema because of these lens particles sticking to the capsule. I did not remove the capsule completely. I should have. Then I did a secondary, because I thought I would put a secondary IOL in this, AC sulcus that I have created. I did that, and the patient had a vision of 6/9 with IOP 14 mm of Hg and with no anti-glaucoma medication. So how I'd like to conclude is, fluffy white deposits in the anterior chamber with increased IOP is a hallmark of lens particle glaucoma. Vitreous cells presence are more suggestive of vitreous inflammation in conditions like posterior uveitis, so you would be having certain amount of retinal choroidal thickness. Endogenous endophthalmitis associated with RCT, thickness increased, but will also have KPs along with the hypopyon. And in atypical cases like this, a UBM can easily tell you that is it a phacolytic glaucoma or something else. Hemorrhagic pseudohypopyon is a feature of leukemic lymphoma or AIDS. So awareness of unconventional presentation of phacolytic glaucoma is pivotal in accurate diagnosis and optimal management. Thank you.
Very nice case. I think it was a diagnostic dilemma which you solved very nicely. Just 2 points, Ankur. Will you label it as phacolytic glaucoma or lens particle glaucoma?
Sir, lens particle glaucoma.
Lens particle, exactly. That's the point I wanted to stress on. Because phacolytic glaucoma is due to leakage of proteins from the intact anterior capsule. Whereas, there was hypopyon, there was severe anterior inflammatory reaction which shows that lens particles had leaked out and which have blocked the trabecular meshwork, causing such great high increase in intraocular pressure. And secondly, you kept the patient on 30 milligram oral steroid.
Sir,
He was what was the weight of the patient?
weight is 60, sir.
So 30 milligram will be, I think, slightly on the lower side, even if we keep 1 to 1.5 milligram per kg body weight.
Totally agreeable, sir. But how do we treat endophthalmitis is till we do not have a vitreous
Till we
depth.
don't have.
So we give half dose of steroids.
Okay.
That's it, sir.
But you, being a retina surgeon, you brought your experience and knowledge to use to the advantage, and you did vitrectomy also, and you found that the lens was totally absorbed.
And I later on did a sulcus implantation of IOL.
Sulcus implant. That was very nicely managed case. Okay, thank you.
Sir.
Now we have Dr. Niharika Batra, and she is going to talk on a headway in an already known phenomenon.
Good morning, everyone. Today, I'm going to present a headway in an already known phenomena, a tale of two diagnoses. A 35-year-old female presented with diminution of vision and redness along with a headache and vomiting in both the eyes. On examination, the findings were similar in both the eyes. There was diminution of vision along with cornea hazy with microbullae, and AC was uniformly shallow throughout, and the pupil was mid-dilated and non-reactive, while the IOP was raised in both the eyes. So the first question was, why bilateral angle closure why a bilateral angle closure attack? Like we all know, the most common mechanism is pupillary block, which is usually unilateral. But yes, it's rare, but it's possible. So the first thing, rarity, was the diagnostic dilemma. Then we considered some risk factors causing bilateral angle closure in our case. So she could be, as she's a female, she could be hyperopic. Thickening of lens would not usually be present because of her age. It could be drug-induced, could be plateau iris configuration, but we'll see that on gonioscopy. On doing biometry, she was not hypermetropic as the axial length was around 22.7 in both the eyes. Then on taking a detailed history, we found our culprit. She was on topiramate just 7 days prior for a pre-existing seizure disorder. Then after consultation with on-duty neurologist, she was withdrawn on topiramate, and the IOP was controlled simultaneously on anti-glaucoma medications. After the cornea cleared, AC was still shallow with inflammation. B-scan findings and ASOC findings also showed ciliocoroidal effusion, which was pointing towards topiramate. So we felt the case was simple and it's closed. It was seemed to be bilateral angle closure attack post topiramate. But on follow-up, the story which we saw was not pointing towards this. There was synechiae in both the eyes, while the fundus was normal in both. And also, even after 2 months of follow-up, the AC was shallow, there was inflammation, left eye had IOP raised, and there were some glaucomatous changes that seemed to be appearing in left eye. So was that just an angle closure attack or a masquerade of uveitis? So there was persistent inflammation that was not responding to steroids, and there was extensive past development. So this patient had drug-induced angle closure attack. Why would the inflammation had so long? And that was not responding to steroids, and there was synechial closure in both the eyes. So it was pointing towards chronic infectious something. So we knew that the peripheral eye dotting was a ticking bomb, but we took a chance to prevent further ocular damage, and we did peripheral iridotomy, and concurrently the complete uveitis panel was initiated to investigate an underlying inflammation cause. This was the picture post PI. On investigation, it revealed that she was HSV IgM positive, but the cornea was absolutely clear and there was no signs of herpetic keratitis. So it was herpetic uveitis with no corneal involvement. On digging literature, we also found that almost 1/3 of the patient can even present without corneal involvement in herpetic keratouveitis. The patient was started on oral acyclovir. So the clinical response to oral acyclovir was excellent, with a significant reduction in inflammation that further confirmed the etiology. So the final diagnosis was both eye mixed mechanism glaucoma with added angle closure attack. So in conclusion, the case began to simply look like just a classical drug-induced angle closure, but the atypical progression, steroid-resistant inflammation, prompted us to look for a masquerade syndrome. So this brings to take-home messages. Firstly, recognizing masquerade syndrome after an acute event is important, as it can unmask the underlying chronic disease. Identifying red flags is important. Expand the differential diagnosis, and the most critical messages: vigilant follow-up is critical and most revealing than the initial emergency presentation. Thank you.
Yeah, Niharika, very interesting case. This shows the importance of regular follow-up in a patient, even otherwise of angle closure disease.
Yes,
Because what happens is you diagnose the case of either PAC or PACS and the patient does not come. You do laser iridotomy and leave the patient. Patient goes back and never returns, thinking that his treatment has been done and no follow-up is required. It was only, I think your history revealed that topiramate was the cause of acute rise of intraocular pressure to 57 and 64 in both eyes. So whenever you have bilateral angle closure, you have to think of causes like this only, because otherwise bilateral angle closure is not a very common entity. It is mostly drug induced. So drugs like anti-migraine like topiramate or antipsychotics, the anticholinergics, they can cause acute rise of intraocular pressure. And your vigilant follow-up where you found that the inflammation is still persisting, that led you to, was the intraocular pressure controlled or IOP was also remained high?
So it remained high up to 2 months till
How
follow-up.
much? How much was IOP?
It was around in 20s and 30s.
In 20s and 30s.
Yes, sir.
Okay. Oh, right. Thank you.
Thank you, sir.
Now we have Dr. Barkha Chaudhary, and Dr. Barkha Chaudhary is going to present on bleb revision as a sight-saving intervention in a patient with chronic and encroaching filtering bleb.
A very good morning, everyone. I'll be presenting my case on bleb revision as a sight-saving intervention in a patient with chronic encroaching filtering bleb. So brief introduction: filtering blebs are key to trabeculectomy success. Few complications, which includes leaks, infections, hypertony, and encroachment of overlying breg. The progressive encroachment of filtering bleb onto the cornea may compromise corneal health and can lead to a visual improvement over time. So the purpose is to present this array as of chronic encroaching bleb with intermittent aqueous leakage, which highlights that the ultimate surgical revision which is done in this patient as a sight-preserving intervention. So this was a 63-year-old male from Delhi. He was asymptomatic otherwise. He was a known case of glaucoma, open angle glaucoma with a right eye advanced glaucoma, left eye moderate glaucoma with both eye phakic, and he was status post-op trabeculectomy in both the eyes. So clinical findings in the anterior segment: the best corrected visual acuity in the right eye was 660, and IOP was 14 millimeter of mercury, and the left eye was 6/12 with IOP of 10 millimeter of mercury. This is the picture of the right eye functioning bleb, which had advanced glaucoma and BCV of 660. And this is the picture of the left eye, which shows the thin avascular cystic bleb, which is encroaching up to the pupillary margin. And there was history of intermittent aqueous leak present, but the patient was being managed conservatively with antibiotics and bandage contact lens as the patient refused surgery. So This was the picture of the left eye bleb picture in 2024, and the below picture is was taken in 2025. That was in January. So the as we see that the encroachment was progressive, and we also saw a few choroidal striations on OCT macula. In the further slides, I'll be showing that. So this is the first photo of the right eye advanced glaucoma and left eye 0.6.7. The left eye OCT macula showed few choroidal striations as well. So this is the visual field of the patient. The right eye tan-2 shows the advanced glaucoma, and left eye has inferior arcuate scotoma.
Can I request the speakers to kindly stay back? We'll have a group photo at the end of the session. Yeah. Yeah, please continue.
Sorry. So this is a surgical video of the patient. When we finally counseled the patient about the need for the surgical intervention, as the bleb was encroaching and there was a history of intermittent aqueous leakage also. So what we did, that the conjunctival dissection was done, and the part which was encroaching of the cornea of the bleb was excised, and post which we sorry. So I don't know what happened. Sorry for the video. Sorry. So then we saw that after excising the anterior part of the bleb, we saw that there was aqueous leak which was positive. And then we completely opened up the bleb for full bleb exploration was done to find out the area of leak. And we found that there was a scleral leak from the side, temporal side of the scleral flap. And then the two scleral flap sutures were given, two 10-0 nylon sutures, and AC was formed with intracameral air, and the conjunctiva was meticulously closed, followed by relaxing incisions which were given in the end to prevent any shortening of the conjunctiva and any retraction in the future. So the post-operative day 1, the visual acuity was 612, and the IOP was 20 millimeter of mercury with well-formed AC, and there was no positive leak on sedals. And there was on further follow-ups, now the patient had improved to 6/9. IOP had reduced to 12 millimeter of mercury with intermittent ocular massage and then no anti-glaucoma medication. The bleb was stable, and there was no recurrence of leakage or encroachment noted till date. So as we know that encroaching blebs can induce astigmatism, corneal compromise, and recurrent leaks. So conservative management is suitable if stable and there's no hypotony, whereas if there's progressive changes threatening vision, the revision is warranted. And one-eyed patients, they need timely proactive care. Thank you.
Very nice case, Dr. Barkha. What are the conservative methods you tried in this? There was only, you found that there was intermittent leakage?
Yes, sir.
Which, how did you detect? By sedals?
Yes, sir, sedals.
By sedals.
Yeah.
So what are the conservative measures that are tried?
So
and what is the indication of surgical intervention?
So we tried. We were intermittently trying with bandage contact lenses and topical antibiotics to prevent any. So we had counseled the patient for surgical intervention, but patient was not willing as he feared surgery because he had only the seeing eye. So we finally counseled him because the bleb was encroaching. Since we compared the picture from the 2024 to 25, so bleb had increased up to the pupillary margin, so that we counseled him that since it is encroaching, even if that time leakage was not there, it was stable, but we had to take the patient for surgery, and on table we found that there was active leak present.
Okay. So your primary indication in this case was encroachment of the bleb onto the pupillary. Yes. Otherwise, you can, besides bandage contact lens, you can try aqueous suppressants.
Aqueous suppressants.
Yeah. You can even try systemic doxycycline or azithromycin. That is also mentioned in the literature.
Thank you.
And measures even like collagen cross-linking has been described in the literature. Okay. Only if there is a leakage or there is hypotony, then surgical intervention is required depending on whether the defect is large or small. If it
Yes,
is small, then conjunctival advancements can be done, but if it is large, then
Then, yeah.
conjunctival graft is required.
sir.
Okay.
Yes, thank you, sir.
Thank you, Dr. Parka. Dr. Mehak is there? No. So we have the last speaker, Dr. Vidushi Dikshit, and she's going to talk on a case of failing bleb and acetazolamide-induced choroidal detachment.
Good morning to one and all present here. I'm Dr. Vidushi S. Dikshit and I'm a second year PG trainee in SSDN Guwahati. I'm here to present a case on a case of failing bleb and acetazolamide-induced choroidal detachment. We have documented this case extensively. However, due to paucity of time, I will try and highlight only the significant points. So here's a case of a 58-year-old male who underwent trabeculectomy with phacoemulsification and subsequent bleb needling, who developed bilateral choroidal effusion a day after, likely due to acetazolamide usage. So he's a 58-year-old male hailing from Assam, who was an already diagnosed case of glaucoma for last 7 years with a positive glaucoma history in mother with a known diabetic. He was already on treatment but was not very compliant with the treatment. This was his previous prescription. As he presented to us, these were his baseline parameters. We noted the visual acuity to be 624 N18 BCVA with a cataractus lens and an IOP of 24, CDR ratio of 0.9 with pale NRR. Therefore, we went ahead and did baseline investigations for the patient, and a provisional diagnosis of primary open-angle glaucoma with cataract with refractive error was made. Thereafter, we started the patient with AGM. However, the IOP was not controlled, remained 24 even after a monthly follow-up. We stepped up the AGM. It still did not get controlled, and therefore it remained 22. Even after the maximal medical management, we could not control the IOP. Therefore, we had to resort to surgical treatment for this patient. On post-op day 1, the IOP was 20. However, after 2 weeks follow-up, it shot up to 25. And that's when we suspected that this could be a bleb failure. And as a resident, I started the patient on acetazolamide. My consultant suggested we must go ahead with bleb needling and MMC. However, next day, to my horror, the IOP shot up to 40 with marked chemosis and congestion, and the AC was shallow in both the eyes. I don't underestimate. I looked exactly like how that Tom is looking. On USG B scan, it revealed shallow choroidal in the right eye and choroidals with suprachoroidal echoes and effusion in the left eye. And we felt devastated as to what happened. But sometimes big problems can have simple solutions. Just discontinuing the acetazolamide, giving mannitol to the patient, an anti-inflammatory and cycloplegic treatment. After 1 week, this patient came back with resolution of these choroidals. IOP was still on the higher side though, but the choroidals had resolved. Eventually, after the patient was still kept on AGMs, and eventually after 1 month, the visual acuity was 6.9 and the IOP was well controlled, 18 millimeters of mercury. The learning point here is that we must keep choroidal detachment in our minds whenever we are prescribing drugs like acetazolamide. The likely etiology here was an idiosyncratic reaction, which I later found out was already described in the literature, but I did not know of. And this could cause a ciliary body edema leading to secondary angle closure glaucoma, which is likely the reason for high IOP in our case. And the signs and symptoms of choroidal detachment must be kept in the back of our heads whenever we are prescribing acetazolamide. And the treatment, as we said, we must discontinue acetazolamide, start the patient on systemic steroids and cycloplegics. Such cases have already been described in the literature earlier as well, which again I found out much later. The learning point is that please, we must be extremely judicious in prescribing acetazolamide. Thank you.
Yeah. Good case, Vidushi.
Thank you, sir.
What is the status of other eye?
So the other eye was absolutely normal to our surprise, but
Quite unusual.
yes,
Quite,
sir.
how old was the patient?
58-year-old, sir.
58-year-old.
He had a positive
Unilateral
history.
open angle glaucoma. Right eye did not
Show any changes.
changes.
We did an OCT RNFL also, sir, which was reportedly normal in the right eye.
Pressure was always normal.
Yes, sir.
Perimetry was normal.
Yes, sir.
That is quite unusual.
Unusual, sir.
Because having only unilateral and that too so advanced, was there any history of steroid intake?
No,
Did
sir.
you take history?
Yes,
Because
sir. Yes, sir.
unilateral open angle glaucoma, you have to find out some other cause also, some secondary cause also.
Yes, sir.
Because it is very unlikely. Although the presentation may be unilateral to begin with, but ultimately it become bilateral. It is asymmetric disease.
Yes, sir.
But having no change in one eye and advanced 0.9 cupping in other eye should make us think that there is something more to it which we are missing.
Yes, sir.
Right. Okay, that's very important message that we give acetazolamide left and right, but we should be aware. Like in this case, there was ciliocoroidal effusion following this, which you could found on this thing, E-scan.
Yes, sir.
And that led us to the diagnosis of the choroidal effusion following acetazolamide therapy, which led to secondary angle closure. So this is not, since it's not a pupillary block mechanism, PI is not going to help, and like you mentioned, pilocarpine should be avoided
Yes,
because
sir.
that will really precipitate. I think any question from the audience, sir? Yeah, Dr. Kashyap, sir.
Sir? Yes, sir. The very next day.
No, you did needling?
Bleb needling, sir.
How many days after phaco and trap? This was combined phaco and trap.
Yes, sir. Sir, it was almost about a month later. We had to after 2 weeks, we found out that the IOP was not controlled, shot up again. That's when my consultant prescribed that we must do.
Just a
bleb
month after
needling.
the surgery, you did
Yes,
needling?
2 months after the surgery.
2 months after the surgery, you did. Sir, misdirection will not lead to, because the choroidal effusion will not occur due to misdirection. It may, misdirection will lead to something like malignant glaucoma. But the patient had documented choroidal effusion.
Yes,
So,
and then there is a misdirection of the echoes from the anterior chamber towards the above the ciliary body and then goes behind the choroid. I had such incidents, that's why I have.
so okay.
Thank you, sir.
Thank you. Any other question? Doctor.
Sir? Yes, sir. Seedles was negative for the patient, sir. There was no likely bleb leak.
So there may be long-term hypertony that might have led to
But sir, the IOP was high on the higher sides.
IOP was 40, I think.
Immediately after, IOP was 40.
IOP was high. So there should have been hypotony. But here the intraocular pressure was very high. Yeah. Okay. Any other questions? Any questions on any of the presentations or any comments? So if there are no more questions, I think we'll end the session. Can I invite all the presenters to be present for a group photograph? I'll request Dr. Podar and Dr. Kashyap also to join.